So her title is about golden hour support during transitional care for very premature infant.
I have no conflicts of interest to declare. The term the golden hour originated in adult surgery, and in fact in trauma surgery. Dr. Adams Cowley is the surgeon who is recognized in North America as being the father of trauma surgery. And he realized that there is a golden hour between life and death. If you are critically injured, you have less than 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later. Similarly, for the very preterm infant, management in the first hour of life is critical, and optimizing that management can have a significant influence on both short-term and long-term outcomes of that infant. The objectives of my talk today are to review the components of the golden hour and to discuss the implementation of the golden hour at our site and to share our experience. With regard to the components of the golden hour, I will spend some time discussing thermoregulation, delayed or deferred cord clamping, the use of oxygen in the delivery room, and the appropriate respiratory support in the delivery room, and also the use of surfactant. Pierre Boudin was probably the first to draw attention to the importance of temperature in newborn infants. He recognized that newborn infants weighing less than 2 kilos at birth, if their rectal temperature fell to between 32 and 35 degrees Celsius, then the mortality rate was 90%. If, however, their temperature was maintained in the normal range, mortality rate was only 23%. This was many years ago and is still not an unrespectable figure. So why are preterm infants particularly prone to developing hypothermia? They have a large surface area to body weight ratio. They lack brown adipose tissue. They have little or no subcutaneous tissue, and they have a very thin stratum corneum, which results in a high evaporative loss, and with high evaporative loss there is consequently significant heat loss. So what do we do to try and avoid these babies becoming hypothermic? First of all, we prepare before delivery to make sure that the environmental temperature is set to 25 degrees Celsius, and also these babies should be placed on a thermal mattress, which should be activated. And please note I'm talking essentially about babies less than 30 weeks gestation, but especially so for babies less than 27 weeks gestation. But for babies less than 30 weeks gestation, after delivery, they should be covered with a polythene wrap or placed in a bag. They should be placed under a radiant warmer, and the temperature probe should be placed in the servo mode. And there probably should be a hat placed on the baby, although the benefit of a hat has been somewhat controversial. Moving on now to delayed cord clamping. In 1801, Erasmus Darwin, who was the grandfather of Charles Darwin, noted, "Another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases." With the medicalization of childbirth in the first half of the 20th century, it became the norm that baby was delivered, the cord was clamped and cut. And this fascinated Dr. Robert Usher, who was the father of neonatology in Canada, because he was interested in what the impact of this was on the blood volume of the newborn infant following delivery. And in 1963, he published figures showing that at 30 minutes of life with immediate cord clamping compared to delayed cord clamping, there was a significant difference in blood volume. Basically, the blood volume difference was 21 mils per kilo. Some 12 years later, he published a paper which demonstrated that those babies, those preterm infants with a higher red cell volume, had a lower risk of dying from respiratory distress syndrome, and he concluded that it was probable that delayed cord clamping by allowing placental transfusion decreased the risk of death from RDS in those infants, and he recommended that the umbilical cord should be clamped no earlier than 1 to 1.5 minutes. It took about another 30 years for various professional bodies to come out with recommendations in relation to when the cord should be clamped following delivery. I've highlighted the ILCOR guidelines of 2010, which were that delayed cord clamping should be carried out for at least 1 minute for those infants not requiring resuscitation. They also stated that there was insufficient evidence to support or refute recommendations to delayed cord clamping in babies requiring resuscitation. And actually, this latter statement is still somewhat controversial today. The next issue became who should be the one to determine when the umbilical cord should be clamped and cut. Should it be the obstetrician or should it be a member of the neonatal team? In general, it was agreed that it should be a member of the neonatal team, and so in 2010, our neonatology group developed delayed cord clamping guidelines, provided an educational rollout, and an important part of that rollout was that there should be a reminder to the obstetrician that at high-risk deliveries, the resuscitation nurse or physician should ask the obstetrician politely to delay clamping and cutting of the cord. In 2021, when I looked at the figures for delayed cord clamping at our center, 60% of babies less than 29 weeks gestation had their cords clamped, with 64% of that group having the cord clamped for more than 45 seconds. Providing optimal respiratory support to these very vulnerable preterm infants is probably the most critical and most challenging part of the golden hour. In utero, the lung is fluid-filled and the pulmonary blood vessels are constricted. Baby is delivered, baby attempts to breathe, the lungs gradually will become air-filled and the pulmonary blood vessels will dilate. However, the very small preterm infant is unlikely to be able to generate enough negative pressure in order to accomplish air breathing in a satisfactory manner, such that there is enough oxygen in the lungs for the baby's PO2 to increase. So how can we help this baby without damaging the developing lung, which is very vulnerable? First of all, the baby has a very compliant chest, which tends to collapse with each expiration. Therefore, we want to try and keep the lung expanded such that this shear stress can be avoided. At the same time, we know that mechanical ventilation is damaging to the lung, and so even positive pressure ventilation ideally should be avoided. So what do we do? Certainly, it has become generally accepted that continuous positive airway pressure, or CPAP, should be applied pretty well immediately after the baby is delivered, and we should use a device that minimizes the work of breathing. And so for the baby who is delivered and who is spontaneously breathing with a heart rate greater than 100, we should apply CPAP. If there is no spontaneous breathing, obviously the transitioning cannot occur. And so if the heart rate is greater than 100, then gentle positive pressure ventilation should be given. If there is no spontaneous breathing and the heart rate is less than 100, gentle positive pressure ventilation followed by mechanical ventilation is probably necessary. Here you can see a newly born preterm infant covered already with polythene wrap, and also already nasal CPAP has been applied. What starting pressure should we use? In general, we initiate with 5 to 6 centimeters of water. More recently, probably we are always starting with +6 centimeters of water. And depending on the baby's response, this may be increased gradually to +8 centimeters of water. Going above 8 centimeters of water generally implies that what we are doing is not enough. We probably have already increased the oxygen concentration, and it may be the time that we should be considering giving surfactant and or intubating the baby. If we give positive pressure ventilation, then the peak inflating pressure that we generally would use would be 20 to 25 centimeters of water. Again, we're always very cognizant of the fact that too high a peak pressure may predispose to pneumothorax. So far, we have not discussed what oxygen concentration we should initiate the stabilization of these preterm infants. And there are certain biological considerations that are extremely important for the newborn when discussing this. We know that increasing the PO2 is an oxidant stress. We know that newborns, and particularly preterm newborns, have minimal antioxidant defenses. We know that at birth, the baby emerges from basically a hypoxic environment, and there is an abrupt rise in PO2, and with that there is a sudden increase in reactive oxygen species. As Paracelsus said, the dose makes the poison. So what dose is appropriate for these preterm infants? When I started in neonatology, we were initiating the stabilization process with 100% oxygen. Following the realization that this was deleterious to the baby, the move then was to room air, similar to term infants. But then it was realized that these babies remained hypoxic probably for too long. And so in general, the starting FiO2 now is 30%. With an initial inspired oxygen concentration of 30%, we will then hope to increase that saturation to attain a saturation of about 80 to 85% by 5 minutes of age. How do we do this? Well, the baby will already have had CPAP applied, and with the CPAP, we will then decide about titrating the oxygen concentration upwards, generally in increments of 10%. Our goal being not to overshoot, not to really go above 95% at any time, and ideally we would want the saturation to be 80% when 5 minutes of age. Having the baby initially stabilized on CPAP and an FiO2 of 30+%, our thoughts now must turn to whether, in fact, this baby requires surfactant. Surfactant was licensed in 1991, and after 30 years of use, we're still discussing who should receive it, what time should it be administered at different gestational ages, what is the optimal dose, what is the method of administration, and what is the best preparation. Regarding how soon after birth should the baby be given surfactant, the European guidelines from 2013 are still very relevant today, and basically babies with RDS who have already been stabilized on CPAP, if they are less than 26 weeks gestation, they should be given surfactant when their oxygen requirements are greater than 30%. For the baby more than 26 weeks gestation, one can probably allow the FiO2 to go up to 40%, but not much higher, before giving surfactant. Of note, if the baby has not initiated spontaneous breathing and is requiring mechanical ventilation, that baby should be given surfactant shortly after intubation and ventilation. Now, of course, babies of 23 and 22 weeks gestation are being admitted to NICUs. For those babies, their surfactant pool is probably very small. They just don't have enough surfactant, and these babies should probably get surfactant administered within the first half hour of life. Traditionally, surfactant was administered through the endotracheal tube, and in general the baby was maintained on the ventilator for some time. However, with the realization that mechanical ventilation is damaging to the lung, it became practice that the baby requiring surfactant could be intubated for surfactant and then the endotracheal tube withdrawn. That was the Insure method, which was established in the Scandinavian countries. Since then, other advances are that surfactant can be administered by nasogastric tube or by a vascular catheter. And here you see a baby of 24 weeks gestation who is being intubated not with an endotracheal tube but with a vascular catheter, and the surfactant is being administered slowly down the vascular catheter. This method allows the baby to be spontaneously breathing. CPAP can be maintained because you can have nasal CPAP being used. And the surfactant does need to be given slowly because the baby is spontaneously breathing. Has this method been proven to be superior to the Insure method? It's debatable. My take on this is that unless you are skilled in the technique of passing an Argyle catheter between the vocal cords and allowing the baby to breathe spontaneously, if you're not familiar with that technique, then potentially it is better to use the Insure method. So I don't think there is any hard and fast evidence that the vascular catheter, or in fact the nasogastric tube, is superior to the Insure method. Not planning to discuss are the establishment of vascular access. It's very important because these babies do require fluids, avoiding hypoglycemia. The administration of caffeine, which can stimulate breathing and improve diaphragmatic activity, and the need for arterial blood gas monitoring. Most important, and again, I won't go at length to discuss this, but communication with the family during this process is extremely important. We have covered all the components of the golden hour. And now comes the biggest challenge, how to implement this in one site. You need buy-in from everyone who's involved in the stabilization of these newborn infants, and also buy-in from the obstetricians. You need champions who will talk it up. You need lots of education, which must be interdisciplinary. There must be great teamwork. And then, once it is implemented, we need to audit all the different components and the processes involved in these components. And ideally, each stabilization should be audited in total and feedback given to the group who have participated in the stabilization. We started our golden hour journey in 2009 by establishing a multidisciplinary working group. And after agreeing on the components to be involved in the stabilization process, we developed transitional care checklists. There were many iterations to these checklists, and they do need to be updated regularly, something that we have not been able to accomplish in recent years, partly because of COVID. Our checklist can be applied for infants born at less than 33 weeks gestation, and here you see the pre-delivery checklist, and here is the post-delivery checklist. At these high-risk deliveries, there should ideally be 3 health professionals: a nurse, a physician or nurse practitioner, and a respiratory therapist. Not every country has respiratory therapists. In Canada we do, but a third person, if there is not a respiratory therapist, could be an additional nurse or an additional physician. Identified on the pre-delivery checklist essentially are the tasks that need to be performed in preparation for the delivery, and you can see that nursing has certain tasks, the respiratory therapist has certain tasks, and the physician has certain tasks. In general, the physician becomes the team leader for the team who are going to be involved in the initial stabilization of this infant. The second part of the checklist is broken down into time segments. We have a 15-minute check, a 30-minute check, a 60-minute check, and a 2-hour, or basically that is the pre-transfer to NICU check that has to be performed. Please also note that in order to simplify things for babies and staff at different gestations, the yellow checklist is for the most immature babies, and the purple checklist is for the more mature babies. Also, on the post-delivery checklist, we have an area for debriefing. This is extremely important for the team who have been present for the delivery. They want to be able to record what went really well, what were the barriers to effective delivery room management, and what were the reasons for variance from the transition process, if there were any deviations. It's really important that this is completed because it throws light on how we can improve things, looking at things on a case-by-case basis. As well as developing and implementing the checklists, we developed an interprofessional one-day workshop for all staff, and the purpose of this was to promote interprofessional collaboration and practice, to enhance a culture of safety, and also to address the needed, at that time, NRP updates, NRP training, and golden hour initiatives. This was very well received, and it was mandatory for all staff who were going to be attending resuscitations of high-risk deliveries. It was mandatory for them to attend. So after implementation, we realized that we needed to continue to build on the work that was done. It's one thing to have checklists to identify what should be done, but we need to audit what exactly is happening in practice. We need to audit simple things like how many babies have temperatures in the first hour of life that are not recorded or that are below 36.5 degrees Celsius. How many babies do not have CPAP started in a timely manner, to name just two. But there are many things that could and should be audited as part of the golden hour. We do need at least to have an annual review of practices, and we ideally should have annual re-education. And what is really important, not just for the golden hour, but for all aspects of neonatal care, we need to continue to promote teamwork, and we need to try and standardize care according to best practices. Thank you very much.
دكتورة داليا, you are muted.
دكتور سامح مع حضرتك.
يعني ابدأي بقى. You can open the discussion with Dr. Mary, please.
دكتور سامح. I would like to thank so much Professor Dr. Sameh for inviting me to this great conference. And it's my pleasure to Dr. Molly for this great presentation. And now we can open the discussion for any questions. Any questions for Dr. Molly? Okay, now we can Dr. Salma, you can introduce now the second speaker.
Hello, thank you very much for inviting me, Dr. Sameh, and it's a very fruitful meeting.